All right.
Okay. So this is our objective for this class. I will cover all the neoplasia of endocrine. Okay. So this is our objective. List the various neoplasm of pituitary, thyroid, and parathyroid, and adrenal gland. Describe the gross microscopic appearance of the above tumor. Explain the clinical sign and symptom associated with the above tumor. List the neoplasm of endocrine pancreas. Briefly describe the clinical features of insulinoma, gaselinoma, explain multiple endocrine neoplasm syndrome. So I will cover all this. So I will cover the pituitary, thyroid, parathyroid, adrenal gland, pancreas, also multiple endocrine neoplasm. Okay? Clear. So pituitary, okay, pituitary tumor. I am not going in detail in pituitary because you already have in the hyperpituitarism, right? The disorder of pituitary gland. I will go just through the most of the histopath part. Okay. So in pituitary tumor we have adenoma or carcinoma. Okay. So usually carcinoma is a very rare tumor, and the diagnosis, the difference between pituitary adenoma and carcinoma only based on metastasis. I mean, the histological features and the clinical features, they are the same, but the difference only the metastatic. Okay, adenoma doesn't metastasize, but carcinoma metastasizes. You still remember the difference between benign and malignant? You still remember, or you already forgot?
Yeah, remember.
Okay, so pituitary adenoma, usually where is the location in cella cervica and derived from adenofacial cells. Okay, affect the body metabolism in the different way. Usually, the importance of pituitary adenoma is the hypersecretion. Okay, and also mass effect. So the pituitary adenoma either by hypersecretion or by mass effect. Okay. So how we can classify pituitary adenoma? Either by morphology or by producing the hormone. Morphology is acidophile, basophile, chromophobe. This is the histological classification. Okay. By the importance in the classification is either functioning or non-functioning. Okay. 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 So we said the classification either by according to morphology or by the whether it is functioning or non-functioning. So functioning is usually the adenoma is a small, okay, and they are produce single hormone or sometimes mixed hormone like growth hormone and prolactin. So they compose of two different cells, okay, and we call functioning and non-functioning. Functioning means secrete hormones, so it's become like hyper secretion, so it can causes clinical manifestation. Non-functioning, which is produce hormone, but you know, sometimes adenoma doesn't produce hormone, some of them, and some of them they produce a little bit of hormone, but not causing the clinical manifestation. Okay. Hello.
Yes, doctor.
Okay, so pituitary adenoma, there is some types like prolactin cell adenoma, which is the most common, 20 to 30%. Growth hormone cell adenoma, mixed growth hormone and prolactin. Adrenocorticotropic hormones cell adenoma. Gonadotropin cell adenoma. We call null cell adenoma. There is adenoma, but there is no, you know, not isolated either growth or nothing, just adenoma. This null cell adenoma is caused the increase and compress the surrounding tissue. Thyroid stimulating hormone cell adenoma and other polyhormonal adenoma. Okay. Usually account 10% the pituitary adenoma of intracranial neoplasm that come in clinical attention, most in case hyperpituitarism due to adenoma. Okay. Usually sometimes incidental finding in 25% of routine autopsy, especially those non-functioning adenoma. Usually affect fourth and sixth decade. Most are isolated and 3% associated with multiple endocrine neoplasia 1. Okay. If more than 1 cm in diameter, we call macroadenoma. Okay, and it is associated with pressure syndrome. If less than 1 cm, we call microadenoma. Most of microadenoma are functioning. Okay. So we start with somatotrophic adenoma. You remember the clinical manifestation? Somatotrophic adenoma secrete what? Which hormone?
Growth hormone.
Yes. So you remember the features? Yeah. Acromegaly or gigantism. You know the manifestation of acromegaly: enlarged head, hand, feet, written jaw, large tongue, soft tissue enlargement. Macroadenoma usually have a local effect, meaning compress the surrounding tissue. Half are densely granulated adenoma and half are sparsely granulated. Third of the adenoma are bihormonal, means also mixed with the prolactin. Usually, most of the growth hormone adenoma is associated also with prolactin, so mixed bihormonal we call. Prolactinoma, most common pituitary tumor, and usually is associated with the infertility in male and female, impotence in male, irregular menses in female, galactorrhea. Two-thirds are macroadenoma and 10 to 15% are calcified. Okay. Corticotrophic tumors secrete what? Which hormone secreted?
Cortisol.
Cortisol.
ACTH.
Yeah, ACTH. So it is associated with syndrome?
Cushing syndrome.
Cushing disease. Okay. Cushing disease means the increased ACTH hormone. Okay. So the source is pituitary. When we said Cushing syndrome, the source where? Adrenal. The source of cortisol is adrenal.
Adrenal.
Yeah, but when we said Cushing disease, the source here is the pituitary. Okay, most are microadenoma at the gonadotrophin, FSH, LH secretion, thyroid adenoma. Okay. This is the, I mean, you are already familiar with all this. We just revise. Non-secretory pituitary adenoma, 20 to 30% diagnosed with pituitary adenoma. Patient is present with sign of mass effect. Why we said mass effect? Because it's not secreting tumor, so it is grow. I didn't give, I mean, the clinical manifestation that causing the, some of them they are secrete a little bit hormone, okay, but I mean not give the clinical manifestation for hypersecretion. So they grow and until they become macro and causing pressure symptom. What's the pressure symptom? The headache, visual field defect, because it's when it is grow, it is compressed. Why there is visual defect?
Because it's compressing the optic chiasma.
Yeah, they can compress the optic chiasma. Okay, so either hypofunction of one target endocrine organs like hypothyroidism, hypogonadism. Sometimes, you know, this adenoma, they grow and compress to the other cells in the pituitary gland. So why the people, they, I mean, the patient can manifest of not hypofunction. Some adenoma, they have, we call null cell adenoma, means when you, how we know this is, I mean, growth hormone or ACTH hormone, we do actually stain for this hormone. If they are positive, that's mean this is secrete something. Okay, secrete prolactin, or secrete HCTH, or secrete growth hormone, as well as the manifestation. Okay, and in functioning, non-functioning, we can see null cells means it's not stained by any hormone. Okay. Oh, sorry. Okay. So look at here. I. We said, oh, we already did this one. Why cannot? Okay, anyway. Okay, look at here. This is pituitary adenoma. This is during autopsy, they remove the brain. See, here is the pituitary adenoma. Okay, and you can see here it's compressing to the optic chiasm here. So the patient may have the visual defect. Also look at here, this is the skull, and this is a very macro adenoma, very big adenoma. So this is, I mean, incidental finding in the autopsy, because they didn't secrete hormones, so there is no manifestation, so the adenoma will grow until give this visual and compression symptom. Okay. For histology, see, this is the adenoma. Most of the, I mean, the endocrine tumor, they are usually small uniform cells, okay, with scanty cytoplasm. Okay. And either sometimes they arrange in diffuse sheets or cords, okay. And by this, in histology, by HNE, we just see uniform cells, and we know this is from pituitary. In this case, we have to do the other stain to know which one. Because under HNE, we don't know how to assess whether it is ACTH which type I mean of adenoma, we have to do the hormone, okay? Either hormone ACTH or growth hormone to know which adenoma belong which hormone, okay? Sometimes we can get necrosis, samoma, hemorrhage. We call this apoplexy. Okay. And usually we said the malignancies look like, I mean the carcinoma look like adenoma in HNE. So we cannot differentiate. Only we can differentiate based on the metastasis. So in this case, we have to do a scan for the body scan, whether it is adenoma or carcinoma. Okay. Understood the pituitary? Any question on pituitary? Hello?
Yes, yeah.
Okay, so now thyroid neoplasm. Sorry. Okay, I will give as like cases. A 40-year-old female presented with solitary nodule in the anterior surface of the neck. Discuss the cause. State your differential diagnosis. So if the patient come in this age, okay, and she has anterior neck nodule, what do you think this nodule due to what? Solitary nodule, not solitary means single nodule, okay? What do you think is due to what?
Thyroid adenoma.
Yes, very good. What else?
Goiter.
Goiter is not solitary. Usually goiter is diffuse, right?
All right. Okay.
What else?
Thyroid.
Lymph node in the thyroid. Okay. How do you know this is this mass arise from thyroid? How do you know?
Because it's located at the anterior surface of the neck.
What else? Maybe in the anterior surface of the neck there is other things like lymph node, something. How do you know this is come from thyroid?
We ask the patient to
The nodule?
and then we can see the movement of the thyroid gland.
Yeah, ask the patient to swallow. If moving is indicate this is thyroid, right? Okay, how to differentiate between the nodule from thyroid or from other parts, like what? How to do? Okay. What else other things of the thyroid? You can see nodules in the neck, in the interior of the neck. Anyone can think? Yes. There is many things, you know. If the patient come with the nodule in the anterior of the neck, what do you think? We said adenoma may be of the thyroid. What else? What do you think? Yeah, could be carcinoma. What else? What do you think?
Viral infection?
What do you mean by thyroid infection?
Like thyroiditis.
If thyroiditis, if thyroiditis, it will be diffuse, isn't it? But we said solitary nodule. Hmm? So, what else?
Mumps.
Mumps. Why you think about mumps? Is it in front of the neck? Hmm? See, oh, I already give you the answer. Okay, see, you have to think first for the benign condition. Okay, what is the benign condition? What do you think? I mean, any patient come, not necessary it is carcinoma, right? What is the most common you can see of the thyroid?
Any viral infections, you might have swelling as well.
Cyst, thyroid cyst is the most common. Okay, thyroid cyst. What else? What else cyst you can see in anterior of the neck?
Thyroglossal cyst.
Yeah, thyroglossal cyst. How to differentiate thyroglossal cyst from thyroid cyst? How?
Patient move the tongue.
Yes. Thyroglossal cyst, when you ask the patient to protrude the tongue, it will move. Okay. Thyroid cyst, ask the patient to swallow. It will move with the swallowing. Okay. What else? This is our differential diagnosis. If the patient came with the solitary nodule, we think first is the thyroid cyst and then thyroglossal cyst. In this case, how we know it is from the thyroid or thyroglossal cyst, we ask the patient to swallow. If move with the swallowing, that's mean thyroid cyst. If the patient with the protrusion of the tongue is moved, is thyroglossal cyst. Okay. Second is the dominant nodule in goiter. Usually, goiter is diffuse nodules, diffuse nodular, but sometimes there is a dominant nodule. Okay, adenoma also, parathyroid adenoma. See, sometimes the parathyroid is become, bigger, so it's feel like nodule in the thyroid. Carcinoma. Mm-hmm. Yeah. Yep. But if it is become bigger, is feel like nodule in the thyroid. Okay. Carcinoma also, papillary carcinoma, medullary, follicular, anaplastic heart cell, metastatic carcinoma, and also lymphoma. Don't forget the lymphoma. This is our differential diagnosis. Okay. When the patient come with the nodule, we think about all this. How we can differentiate it in all this? What we should do? What is your investigation?
TFT. You do a TFT.
State your investigation. What are we going to do? Allah. What's this? State your investigation. What are you going to do?
You do a thyroid functioning test.
What is the thyroid functioning test?
You check all your TSH levels, your thyroid hormone levels.
Yep. Then, after that, how we do? First, we have to do the TSH hormone, right? Okay. If TSH hormone low, indicate what?
Hyperthyroidism.
Yes. If TSH hormone high,
Hypothyroidism.
If normal, normal? Normal thyroid.
Sick thyroid.
But the patient still have the thyroid nodule. If we check the TSH normal, so we exclude hyper or hypo, right? Okay. In this case, what are we going to do? We just leave the patient to go to home or what?
You do T4 test.
T4. Okay, if the hormones is normal.
Do a scan, maybe?
What is scan?
A CT scan?
CT scan. So we have. I mean, we have. I mean, simple. I mean, investigation before that. So what are we going to do? We have ultrasound. This is easy. The one ultrasound. We do ultrasound, right? Okay. If okay, by ultrasound, I mean the ultrasound in the what we see in the ultrasound. We can see if it is cyst.
The hotspots.
Hotspot by ultrasound cannot.
Radioisotope.
Check for nodules.
Yeah. By ultrasound, you can see whether it is solid or cyst. Okay. In this case, we can do what? After that.
Radioactive iodine.
Can. For example, if we see is fully cyst, and sometimes there is cyst plus some solid inside. In this case, if we see suspicious like that, what are we going to do to know what's
FNAC?
Yeah, FNAC. Okay. Also, or we can do if solitary nodule and solid. In this case, we can do the radioisotopic scan to see whether it is hot or cold nodule. Hot. What does mean by hot nodule?
It secretes a lot of thyroid hormone.
Yeah. Cold nodule means what?
The metabolism of the thyroid hormone is high in that specific area.
Cold nodule.
Either inactive or it can be malignancy.
Yes, because the cold nodule not active. In this case, we suspect what? Suspect neoplasm. Okay. Sorry. Okay. So we do see this is what we are going to do first. Patient with thyroid nodule, we do the TSH hormone. If low TSH hormone, we do radioisotopic scan to see whether hot nodule. Okay, and if normal, in this case, usually before the FNAC, we do the ultrasound actually, because ultrasound is very, very nice to see whether it is just cyst or cyst with trabeculation, means there is some solid area, or just solid. In this case, we send the patient to do the FNAC. FNAC, we can take the cells, okay, so and we can assess whether it is malignant. Okay, in this case, we have to do the surgery. If indeterminate means we cannot assess. In this case, we do radioisotopic scan. Whether to see it is cold nodule, we can do a surgery. If not, hot, This case we have to do the observation. And if by FNAC is benign, most of the nodule is benign, you know, about 70%. So in this case, just observation, no need for surgery. Okay. If non-diagnostic mean, what is non-diagnostic? Sometimes we didn't aspirate very well or less cellular. In this case, we have to do repeat FNAC. Okay. This is what we do. How we, this one radioisotopic scan. What do you think? This picture for what? Indicate what?
Hyperthyroidism.
This one. So what about this?
Hyper.
Diffuse, homogeneous.
Mm-hmm. Okay. Indicate what?
Graves' disease.
Mm-hmm. And this one indicate what?
Multinodular goiter.
Yeah, very good. This one indicate what?
Solitary adenoma.
What about this?
Solitary adenoma.
Mm-hmm. Indicate what? Which we call cold nodule. This one is normal. You know, when do the isotopic radioisotopic sensor, the distribution is normal, means all homogeneous. This one is diffuse hypersecretion, hot, the whole gland. This is indicate the Graves' disease. This one is multinodular goiter. You can see areas is hot and some areas is normal. So this is indicate multinodular goiter. Here you can see this is one the normal area, but here in this area is a cold nodule, not uptake the iodine. Okay, so this is cold nodule, no secretion of the thyroid hormone. Okay, in this case, maybe is what? Neoplasm. Okay, because most of the neoplasm is the cold nodule. Why we said neoplasm? Neoplasm is indicate what? We say thyroid neoplasm indicate what? Anyone? Yes.
What do you mean, doctor?
Neoplasm. When we said thyroid neoplasm, indicate what?
Abnormal growth of mass.
Is either adenoma or carcinoma. I cannot say just it is a carcinoma. No, adenoma or carcinoma. Neoplasm means indicate both adenoma or carcinoma. It means benign or malignant. Okay. Okay. We said if the result of the thyroid nodule benign, so follow up 6 to 12 months. If cyst, also follow up. Indeterminate, we said we have to repeat FNAC. When we said follicular neoplasm, in this case, surgery. Suspicious, maybe suspicious carcinoma. Also, in this case, we have to remove the thyroid. If carcinoma, also we have to remove the thyroid. Why we said follicular neoplasm? Why we didn't say follicular carcinoma or adenoma? Can we diagnose follicular carcinoma in FNAC or adenoma? Anyone know? Actually, in follicular neoplasm and follicular neoplasm, we cannot say in FNAC this is adenoma or carcinoma. Okay, because we have to assess the capsule. Capsule, we cannot assess in FNAC. Okay. So sorry. This one, you know that this is the FNAC. FNAC, fine needle aspiration cytology. Usually we do the the normal syringe there, okay, and we put the needle there, and we fix with the plunger, and when we take the cells, we spread to the slide. You can see here. Yeah, like that. See, look at here. This is that we fix the needle, the syringe there in the plunger, and we ask the patient to lie down and expose the thyroid. So first we examine the thyroid, ask the patient to swallow, so we can assess where is the nodule. Then we insert the syringe through the nodule, under pressure. Once we put the needle, we take the pressure and we insert several times until we can see here some cells there. Then we spread to the slides and then put it in the alcohol, and we have to processing for the staining. See, it is easy. It can be done in the outpatient, the process. Okay. So this is with the fine needle aspiration. See, look at here. This is the normal thyroid. So we can see like honeycomb. Okay. So you can see this is the and the background have the colloid. See the cells where is not. I cannot see. I can tell you. I cannot see. I mean, we can see it is uniform, the same size. No, a bit different size. See, this is a small. This is a bit bigger, but they are abundant. Okay, and like honeycomb, and the background also you can see the colloid there. See. Okay, this is the normal, the aspiration of normal thyroid. But our case, look at this, our case. This is the patient who come with the solitary nodule. What do you see here? Is it like the previous one?
Cells are less abundant.
Mm-hmm. And the cells are, they are arranged like follicle, isn't it? Do you see here what we call colloid? The background is devoid the colloid. This means there is no colloid, but there is some cells are arranged like a follicle. In this case, it's not normal, this one. Okay? In this case, what we call, because like a follicle, we call follicular what? Carcinoma or adenoma?
Carcinoma.
Why is it carcinoma? No adenoma, no carcinoma. I just mentioned, remember, neoplasm. We cannot say this is adenoma or carcinoma because there is a criteria for diagnosis of follicular carcinoma. In this case, we cannot assess the capsule. Can you see any capsule? Cannot. In fine needle aspiration. In fine needle aspiration, only we can see the cells. Okay? So this is the cells are arranged in follicles and no colloid. That indicate this is abnormal. And when we see like this kind of cells and arranged in the follicle and no colloid, in this case we can say follicular neoplasm. Okay. Once we report follicular neoplasm, in this case, they have to do what? Just release the patient, or what are we going to do?
Yeah, to do more tests.
Which test? What we should do if we report, if you get the report from histopath, the cytology indicate follicular neoplasm. Yes, surgery. In this case, we have to remove thyroid, not the nodule. We have to remove the whole thyroid, you know, total thyroidectomy. Okay, cytology result is the follicular neoplasm. Okay, this is the not biopsy, the thyroid. Okay, look at the here is solitary nodule, well demarcated from the thyroid. Okay, look at here, they are surrounded by very thin capsule, isn't it? But we can see the capsule. I mean, it is surrounding the whole nodule. Okay. Okay. This is the typically solitary spherical encapsulated, well demarcated from the surrounding thyroid parenchyma. Okay, you can see. Look at here. This is histology. Histology is different from cytology. Cytology, we can see only the cells, but histology, we can see all the tissue of the thyroid. So this is the normal thyroid. See, look at this is the follicles, and you can see the difference, isn't it? They are small thyroid, closely packed, isn't it? And they compressing the surrounding tissue. This is the capsule. Look at the capsule there. Okay. In this case, what we can say, is this carcinoma or adenoma? What do you think? We said homogeneous architecture with capsule different from outside the capsule, expansile growth compressing the surrounding non-neoplastic thyroid tissue. This is non-neoplastic, and this is the neoplastic or the tumor. So what do you think? Is this carcinoma or adenoma in this case?
Adenoma.
Yeah, adenoma, because we can see the capsule is intact capsule. You know, the difference between adenoma and carcinoma is the invasion of the capsule. In this case, it is you know, it is very difficult to diagnose the follicular carcinoma because you have to assess the capsule. Okay. So what is your diagnosis? Is follicular adenoma. Okay. Other case. This is the case. What we have. This is solitary nodule. Can you see? Look at the capsule. The capsule. Remember the adenoma one? Very thin capsule. This one is thick capsule, isn't it? See, look at the capsule. If they are surrounding the nodule until this area. Can you see here any capsule?
No.
No. In this case, maybe there is invasion. Other things we have to see whether there is necrosis, okay, or hemorrhage. I mean, this indicates from the gross we can see maybe it is malignant or something. Okay. Look at here. This is the normal thyroid. Okay. I mean, no capsule. Look at the capsule here. Is there any invasion? No. Capsule is intact. Okay. In this case, look at the capsule, very thick. But here, what do you see here? Look at, this is the tumor cells, and they are go inside the capsule. This is indicate the invasion, capsular invasion. See this one. This is the tumor cells. See, and this one is the capsule. Look at the tumor cells. They are invading the capsule and they forming like mushroom, isn't it? This is also capsule. See, we have to assess. We said the capsule. This is the important things in the thyroid carcinoma. So look at here the mushroom invasion of the thyroid carcinoma. Here is vascular, but the vascular, how? We have to assess the blood vessels inside the capsule. If there is tumor cell inside there, this indicates the vascular invasion, okay? So how we can diagnose the follicular carcinoma? By capsular and vascular invasion, or capsular invasion is enough also, okay? There are two invasion. We said minimally invasive and extensive invasion of the capsule. Minimally invasive means if there is like the previous picture, remember this one we indicate the minimally invasion, small part of the capsule is invaded. But this one, if there is transaction, I mean the full capsule is invaded, this is we call capsular invasion, okay? So what is your diagnosis? We said follicular carcinoma in this case, not follicular adenoma. Understood? Faham?
Yes.
Okay. So what is the prognosis of patient with follicular carcinoma? What do you think? The prognosis of patient. If we said minimally invasive, the prognosis is a good or bad?
Good.
Yeah, in case the overall is about 92%, 10 survival. Prognosis is better if the lesion is minimally invasive, and worse if widespread capsule and vascular invasion or visceral metastasis. Usually the follicular carcinoma, they tend to metastasize to the other tissue like lung tissue, bone. The follicular carcinoma is more aggressive than papillary carcinoma. Papillary carcinoma is usually metastasized to lymph node, but this one is vascular metastasized. Okay. Other case, and second case is 47-year-old woman has felt a lump in her neck for past 2 months. On physical examination, there is a firm nodule in the right loop for the hair thyroid. Patient has history of neck radiation. Put under neck radiation 2 lines. Indicate what? If patient have history of neck radiation, what did you expect? What type of tumor there?
Carcinoma.
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 Yeah, what type of carcinoma have a history of neck radiation?
Malignant.
Yeah, I know malignant. What type of malignant? Okay, I will show you later. Okay, so what is your investigation? We said a patient come but nodule. What is your investigation? We said. Remember, we just mentioned we have to do the hormones, TSH hormone. If normal, we have to do ultrasound. We see whether it is cyst or solid cyst. Then FNAC, right? So if NAC show this, what do you see? What do you see? Look like what? See, I just go through the arrow is indicate what? The shape, what do you think the shape is what?
Irregular.
Yeah, regular, like finger-like process, right? Isn't it? Okay, okay. What do you see here? This is a high magnification of the cytology. Why the cells? What? This is the cells. Why? What inside the cells? What are these? What are that? What are these?
Mitosis.
Red blood cell.
No, this is the cell. Okay, of the tumor. But what do you see inside the nuclei? Isn't it? What is this line? Okay, if you look at the cells, it look like what?
Bean shape. Bean shape.
Have you seen before the coffee bean?
Yes.
Yeah, it's like coffee bean, isn't it? Actually, this one is we call internuclear groove. See, dividing the nuclei into like two halves, isn't it? But actually, is not really internuclear groove. It's like because the cells are folded like a coffee bean, they forming like internuclear groove. Okay. This one we call intranuclear inclusion. Intracytoplasmic inclusion means because the nuclei are invaginated. Okay. They took part of the cytoplasm inside the nuclei. Okay, so they forming this intercellular internuclear inclusion. It's like inclusion. It is eosinophilic because it is part of the cytoplasm. Okay. Other features. Look at here. This is once we see this. Okay, sorry. If we see like this one, wait. Okay, if we see in the cytology like this, irregular shape, okay, and these features. So it is normal.
No.
Is it normal? No. Remember the normal, how is it? It's like honeycomb, isn't it? And abundant colloid. But if we see a regular shape of cells and no colloid, and you can see these features of the cells, nuclear groove, coffee bean, and intracellular inclusion, internuclear inclusion. In this case, it is it's abnormal. In this case, we can call what? Features of what? And the patient have radiation, history of radiation. What do you think? In this case, we report what? These features of what?
Malignancy.
Yeah, malignancy. Which type of malignancy? See, I showed this one. We said irregular finger-like process. Indicate like what? Which malignant can give this irregular and finger-like process? Papillary, actually. You know, in the cytology, we can report or we can diagnose papillary carcinoma because papillary carcinoma have unique features. First, we can see no colloid background, no colloid. Second, hypercellular and with irregular shape, which is papillary shape. This is papillary finger-like process. And the second is the most important is the nuclear feature. Nuclear feature is what? Is internuclear groove, okay? Also intranuclear inclusion, okay? This is the conclusion. So in this case, if we see these features, we report directly is papillary carcinoma. In this case, what are we going to do?
Doctor, you're muted.
In this case, what are we going to do? If we report papillary carcinoma, what is the management of patient in this case?
Surgery.
Surgery. We have to do the total thyroidectomy. Okay. Okay. In thyroidectomy, this is the specimen. So in this case, either we can see in the papillary either solid tumor. You can see the irregular. Okay. In follicular, we said we see solitary nodule with capsule, right? But in papillary carcinoma, usually we have solid with the irregular surface, or this cyst. Look at this. This is a cyst, and inside is papillary. Okay, papillary carcinoma. So when we do fine needle aspiration, if we aspirate, we can see the fluid. We have to aspirate until there is no fluid, because if we just aspirate and leave some fluid there, and we didn't do many times insertion of the needle, maybe we missed this area of papillary. Okay, because if there is cyst in the thyroid, either maybe colloid cyst or normal thyroid cyst or papillary carcinoma. Usually the ultrasound is assessed. Ultrasound can assess whether it is just cyst or cystic solid. I mean, they can see that trabeculation and under ultrasound. Okay. During fine needle aspiration, we have to aspirate the whole fluid, because in normal thyroid cyst, when we aspirate, so no need for other management, because we aspirate the whole fluid, and the cyst can be regress. Maybe sometimes if you aspirate fully aspiration, so the cyst cannot be, back. This is in normal thyroid cyst. But if there is papillary carcinoma, you can see there is fluid in cyst plus the solid area. In this case, we have to aspirate the whole fluid, plus we can have to insert several times to get some cells, maybe indicate we can miss this area. Okay, understood? Okay. You understand me? Hello?
Yes, Doctor, we understand.
Understood. Okay. So this is in papillary carcinoma. We said there is sometimes often cystic with papillary structure. May contain area of fibrosis or calcification. Look at here. This one is there are two forms of we said of the papillary carcinomas. Either we cannot see the cysts, just the solid area with the irregular surface. See here, there is no capsule in the papillary carcinoma. The capsule, just the solid area with irregular border, or oh my god, or the cystic area. See This is the normal thyroid, normal thyroid tissue, and this is the cyst. Okay, inside the cyst there is a papillary structure there. Okay, so in histology or in sectioning, we can see, look at this papillary structure there. The papillary structure is lined by this kind of cell. Look at the high powerful. What do you see in the nuclei? What do you think? This nuclei is what?
Intranuclear occlusion.
Mm-hmm.
Intranuclear occlusion.
No. Look like what? The nuclei. Ground glass, isn't it? We call ground glass or empty nuclei. Remember, in the cytology, we cannot see this ground glass, isn't it? But in histology, we can see the ground glass appearance. Ground glass. What does it mean by ground glass? Means that, you know, the center of the nuclei is empty and the border of the nuclei is thick. It look like the glass, the ground glass, or empty nuclei, or you can say orphan any eye. This is the name of the papillary carcinoma. This one is samoma body. You can see also samoma body. What else we can see? See, look at here. Nuclear groove. We said you can see internuclear groove. Okay, and this one the inclusion, intranuclear inclusion. We said inclusions is invagination from cytoplasm inside the nuclei. Okay, understood. The features of papillary carcinoma. So what is your diagnosis is thyroid papillary carcinoma. So usually how to diagnose the papillary carcinoma is branching papillae. Okay, having a fibrovascular stalk covered by single or multiple layer of cuboidal epithelium. But this is not enough. Even the name is papillary carcinoma, but if we say papillary branching papillae, is not enough to diagnose thyroid carcinoma. What other features? Very important, we said. The nuclear features. Nuclei of papillary carcinoma should be characterized by optically clear or empty appearance or ground glass appearance or orphan any eye we call. Okay. Second is internuclear inclusion, which is we call pseudo inclusion. Why we said pseudo inclusion? Actually, is not true inclusion. Is invagination of the cytoplasm. Okay. Third is nuclear groove. Okay. This is the features to diagnose the papillary carcinoma. Faham?
Yes.
Because sometimes, you know, we can see papillae in Graves' disease, but doesn't have these features. So the important, if we see papillary structure, we have to look at the optically clear, intranuclear inclusion, and nuclear groove. So to diagnose the thyroid carcinoma. So this is the characteristic feature of the thyroid carcinoma. Plus samoma body we can see, okay, but samoma body is not, the diagnostic features of the papillary carcinoma. We can see samoma is usually in the core of papillae, but the most important is the ground glass, intranuclear inclusion, and nuclear groove. Okay. So what is the risk factor of the thyroid cancer? We said, what is the risk? One of the risk factor is what? We said, we just mentioned in the history, remember?
Radiation.
Yeah, radiation. Nick, radiation is very important. Ionizing radiation is, especially in infancy, is related to the papillary carcinoma, actually, ionizing radiation. Genetic factors, like what? Some papillary carcinoma have inherited syndrome like adenomatous polyposis, Gardner syndrome, Cowden disease. Also familial medullary thyroid carcinoma. in case of multiple endocrine neoplasia type 2 associated with RET proto-oncogene. Remember what is the proto-oncogene? What is the proto-oncogene?
Growth promoting gene.
Yes. So if there is, actually this is RET gene is important for the development of the thyroid tissue. If there is mutation, it will be transformed into oncogene. Oncogene, it leads to the formation of the cancer. So it is associated usually with medullary carcinoma. Okay. Also, pre-existing thyroid disease, like they said, long-standing multinodular goiter may lead to the development of the thyroid carcinoma. Hashimoto's thyroiditis also, it leads to the thyroid lymphoma. Okay. Understood this risk factor? Okay. Do you want break or we can continue?
Maybe we can have a little break.
Okay. Okay. 5 minutes break.
Alright.
Okay. Hi. Hello. Okay. Can we continue? Hello.
Yes, doctor.
Can we continue?
Yes.
Okay. A 37-year-old man present with a single fold mass within the thyroid gland. This patient father developed a tumor of thyroid gland when he was 32 years of age. Okay, when we said there is father development, it indicates what? Family history, right? Isn't it? Which type of tumor do you think has a family history?
Adenoma.
Medullary carcinoma. Medullary carcinoma, we said it is familial. Remember, RETG. Okay, you can see this is a tumor. So what is this one, which is eosinophilic, structureless, extracellular?
Connective tissue.
I don't think it's a connective tissue. This is amyloid, actually. This is the neoplastic cells, see? This is which is oval cells, tumor cells. Within there is amyloid. Amyloid is the, remember the amyloid? Have you remember the amyloid, the extracellular protein?
Yes.
Is associated with the medullary carcinoma of the thyroid, actually. It is due to what? What do you think? From where the amyloid come?
Calcitonin.
Yes, very good. Because these cells is parafollicular cells. They secrete the calcitonin. Okay. So the amyloid is a homogeneous extracellular material derived from calcitonin molecule secreted by neoplastic cells. Okay. So how we confirm if we see like this? How we know this is amyloid? What we should do?
Congo stain.
Yes, Congo red stain. Very good. What is the further test? This is the Congo red stain. See, it's look under light microscope. We can see red color. The amyloid is give red color with Congo red stain. By polarized microscope, we can see this is what we call apple green perfringens. Is become bright like apple green. Okay. If we see this one, is indicate the amyloid. Okay, faham? This is the apple green perfringens. This is indicate the amyloid with Congo red stain. Okay. See the amyloid under light microscope, we can see the red color. But once we put the polarized microscope, it gives this bright apple green, isn't it? Perfringens. Apple green perfringens is bright. Is appear is the branching like branching apple green. Okay. Apple green perfringens under polarized microscope. Okay. Faham? So what is your diagnosis? We said is medullary carcinoma. Actually, medullary carcinoma is considered a neuroendocrine neoplasm of the parafollicular C cells. Secrete, because neuroendocrine, they secrete calcitonin, also can secrete ACTH, prostaglandin, serotonin, CEA. Okay, Usually it is associated about 20 to 25% are associated multiple endocrine neoplasia type 2A and type 2B. The sporadic is 80%, but the few percent can associated with multiple endocrine syndrome. Okay. Okay, understand the thyroid neoplasm. We have the most important is the thyroid, papillary, and medullary carcinoma. Okay, there is other neoplasm, but I give you the most common. You have also anaplastic thyroid carcinoma. You have heart cell carcinoma. You have lymphoma. But the most common is the three tumor: papillary, medullary, and the thyroid. Okay. So for parathyroid gland, the disorder to the gland is produce autonomous hypersecretion of parathyroid hormone. So it leads to the hypercalcemia and hypophosphatemia. Okay, the major cause is the adenoma. The most majority is the adenoma. Also primary hyperplasia, parathyroid carcinoma. How we differentiate between adenoma and hyperplasia? Adenoma is usually single nodule and also parathyroid carcinoma, single nodule. Primary hyperplasia, usually the four loop are hyperplastic. Okay, since you see this is the parathyroid adenoma, usually if hyperplasia, we can see the four loop are hyperplastic. So we can see hyperplasia of most of the cells. Adenoma, usually we can see there is capsule and small cells are compressing the normal tissue. For parathyroid carcinoma, how we suspect if there is very high level of calcium, more than 40 milligram, okay, and also recurrent hyperparathyroidism after surgery. Histology usually uniform is not dissimilar from normal nodule trabeculae, but the important is the local invasion and metastasis. See, this is the tumor carcinoma. See, look at here, we can see the tumor are invading the capsule there. This is the capsule. If the tumor is invading capsule, is indicate parathyroid carcinoma. And we said if there is very, very high calcium, we suspect the carcinoma rather than adenoma. Adenoma, usually there is no invasion to the capsule. Okay? Understood? Faham? So we can move to adrenal gland.
Doctor,
Yeah? Yes.
how did you say we can differentiate with hyperplasia?
Hyperplasia is hyperplasia is usually most the four loop. Okay.
Alright.
Second, there is no capsule. It's like usually by growth. They said increase the size of the gland, but when you look at the histology, remember there is no like adenoma, single nodule, right? See here, there is no demarcation between the normal and the abnormal area. Okay, you can just see the hyperplastic of the cells. But in adenoma, see, look at here, adenoma, you can see the difference between the normal and abnormal area. Normal area is most closely packed and they forming the single nodule, plus there is a capsule there. Okay. For carcinoma, look at here also they like, adenoma, but they have invasion to the capsule there. Understood?
Yes, thank you.
Okay, adrenal glands. Okay, for adrenal gland, we have the cortical area and the medullary, right? Yeah. Okay. So cortical neoplasm, as you know, you already covered isn't it, in the adrenal disorder, right? Just functioning tumor is associated hyperaldosteronism and Cushing syndrome. So I'm not going through the all manifestation of Cushing and hyper because already covered, right? So we just see what is the adenoma and what is the carcinoma. Both adenoma and carcinoma, if there is adenoma and carcinoma, is associated with hypersecretion of aldosterone and cortisol. Okay. It leads to the hyperaldosteronism and Cushing syndrome. Okay, most of the adenoma are adjacent to the cortex, is normal, so they arise from the cortex of the adrenal gland. Okay, cortical carcinoma usually they are large, okay, and about 20 cm. See, but if the adenoma usually 2.5 cm, but if carcinoma you can see 20 cm. Yellowish and hemorrhagic cysts. Okay, and mild atypical or anaplastic cells. Okay, for medulla, adrenal medulla, this is the important pheochromocytoma, neuroblastoma, and ganglioneuroblastoma. You already covered this or not?
Only pheochromocytoma.
Only pheochromocytoma. Fully covered, isn't it? Okay, for the pheochromocytoma, we call paraganglioma of adrenal gland is uncommon, but when happen there is a lot of catecholamine, so it induces the hypertension. So the patient usually have manifestation of high blood pressure. Okay, so and sometimes it's associated with the Cushing syndrome. 85% arise from adrenal medulla, and the remainder may be from the extra-adrenal, which is paraganglion sepsis. Any part of the sympathetic chain, okay? We call paraganglioma. The important thing is how to diagnose the pheochromocytoma when we measure urinary vinyl mandelic acid, BMA, for confirmation, okay? If you see some books, they put 10% bilateral, 10% extra-adrenal, 10% malignant, 10% familial. This is in the old box. Now is this all this fact is changed. Okay. How the gross features is usually pale gray brown, hemorrhagic. Maybe we can see necrosis, cyst, mature appearing medullary cells, or maybe you can see giant bizarre cells. How to differentiate between a pheochromocytoma, the benign, and the malignant is by metastasis. We cannot, differentiate between the pheochromocytoma and the malignant pheochromocytoma only by metastasis. Okay. Have you seen before the adrenal medulla? Adrenal gland. The normal adrenal gland. Have you seen before?
Yes.
This is the normal. The normal adrenal cells. They are small, about 3 to 5 cm, and is look like yellowish color. Okay, this is the normal area, normal adrenal gland. This one is the pheochromocytoma. See, solitary nodule, yellowish usually, and it is compressing the normal tissue. See, this is the normal tissue, and this is the adenoma. Why it is black color when we fixed with the zinker, because it is, if turned to the black color, it indicate the positive chromatin reaction. Okay, understood? But in this case, we have to receive the adenoma, this one, the pheochromocytoma, fresh, not under the fixed, under formalin. Once we receive this fresh, we put the zinker. If turned to the black color, this is indicate dichromaffin reaction. That means this is the pheochromocytoma. So we can even diagnose through gross. Okay. So the histological features of pheochromocytoma, you can see like ball, we call the pollen. Okay, gel pollen or cell ball growth pattern surrounded by fibrovascular tissue. Okay, and it is composed of chest cells. Can you see? This is the cells are granular. Can you see the cytoplasm is eosinophilic and granular? Okay. Hyper reveal the chest cells abundant granular cytoplasm with nuclear polymorphism. Remember what's polymorphism is what? Polymorphism. Variation in the size, isn't it? And shape of the cells. So you can see some polymorphism. I mean, polymorphism we said is the features of malignancy, but not necessary because see we said pheochromocytoma, it's adenoma, okay, it's not malignant. We can see the polymorphism is okay. The difference between the pheochromocytoma we said and the malignancy is metastasis. Okay, sometimes we can see necrosis. That means it's not indicate the malignancy. Only metastasis is the indicate malignant. Faham? Understood?
Yeah.
Yeah, because I remember I did one case. Then the clinician, they call me. They want to know is it malignant or benign. I told them you have to tell me whether it is malignant or not, because both a pheochromocytoma, the malignant and benign, look similar in histology. So we just want to know then if there is metastasis. So I told him you have to tell me whether it is metastasized or not. You have to do the scan. We cannot tell based on the histology features it is malignant or benign. It's just by metastasis. In this case, we have to do scan for the whole body whether there is metastasized or not. Okay. Neuroblastoma. So neuroblastoma is a highly malignant tumor of infancy and childhood. Okay, and also maybe congenital or arise in anywhere sympathetic nervous system from the head to pelvis. Okay, elaborate catecholamine and produced elevated level of their metabolites for VMA. So if you see the child, if we see the child with the high so it is arise from the sympathetic nervous system. If you see the child have the VMA or elaborated catecholamine, in this case we cannot see pheochromocytoma. Is the neuroblastoma. Okay, and the patient usually present with the abdominal mass. Okay, so gross description is soft tan with hemorrhage. So in microscopic feature, usually we said neuroblastoma. Omoblastoma is a primitive cells, usually small cells with scanty cytoplasm, and they are hyperchromatic nuclei. Usually they form what we call hemorrhoid pseudorosette. Okay, and this tumor usually secrete NSE, chromogranin, and synaptophysin. You can see this is the abdominal mass. Okay, look at here. Can you see the cells? They are small cells, scanty cytoplasm, right, and hyperchromatic nuclei, and they form what we call pseudorosette. Can you see this? Like, look like the the rosette, isn't it? They are trying to forming the pseudo rosette. We said is not true rosette. Is like is around the neuropil. If you see the around there, this area is neuropil is like white matter. فهم? Understood?
Yes.
This in this case, if we see like this tumor, and we suspect most of the blood, most of the we call this kind of blue round cell tumor. Blue round cell tumor is neuroblastoma, give these features, medulloblastoma in the brain also give like these features, small cell with scanty cytoplasm and hyperchromatic nuclei. Also nephroblastoma in the kidney, okay. Ewing sarcoma, small cells like this. In this case, we have to know the history. If we get like this kind of specimen, we have to get the history of the patient, what he has, because also, retinoblastoma, it gives this kind of tumor, I report one case, the patient have proptosis. Proptosis means the eyeball is, is protruded to the outside. And they give the biopsy. When I look at it, I suspect retinoblastoma, and they are similar in histology. And even I did the special stain. We said in special stain, remember there, they secrete this kind of hormones, NSE, chromogranin, synaptophysin. I did these markers, NSE, chromogranin, and synaptophysin is positive. Also, retinoblastoma give the same of positive. So I give differential diagnosis. Maybe is neuroblastoma or retinoblastoma. So I asked the surgeon to do the scan of the body. Okay. When they did the scan of the body, they found there is the sympathetic ganglia of the whole body is enlarged. That means this indicate neuroblastoma more than retinoblastoma. Understood?
Yes.
Yeah, doctor, but I'm sorry. What scan can allow you to see that the whole sympathetic ganglia is?
Yeah, we do the CT scan.
Oh, okay, all right.
Yeah. CT scan, because there is a different management of neuroblastoma or retinoblastoma. Get different, because not only, the histology can give we have to correlate the history, the other investigation, okay, because some tumor is similar to each other, okay. Okay, next. So we said right, rosette neuroblastoma. Rosette means like flower, making like flower, okay. We have finished the adrenal. We have now pancreas. I'm not going through through the pancreas, because you already covered most of the pancreatic. The endocrine, actually, they are, some area is covered by different part. Okay, so alpha cell, we said glucogenoma is already covered. Beta cell, insulinoma, delta cell, somatostatin, PP, pancreatic polypeptide, gastrinoma, vipoma. You already covered all this, isn't it? I just go through insulinoma, because in insulinoma it indicates that the tumor is secrete insulin. If you have high level of insulin, what do you think? Severe hypoglycemia, isn't it? So it is produced not only, because severe hypoglycemia we call neuropsychiatric. Okay, because the effect of hypoglycemia is causes neuroglycopenia, which is causes headache, confusion, visual disturbance, seizure, and personality changes. Okay, in response to this neuroglycopenic stress, the body generates compensatory state of catecholamine excess, which is leading to palpitation, weakness, tachycardia, and irritability. Okay, understood? The last thing is multiple endocrine syndrome. Okay, we have multiple endocrine neoplasia. Okay, we have a group of inherited disease result from proliferation, lesion, hyperplasia, adenoma, and carcinoma. Sorry, actually, my children opened the TV. So I asked them to close the TV. Okay. We said multiple endocrine organs will be affected. Okay. So usually most of the multiple endocrine neoplasia occur in young age, and then sporadic tumor, even one organ tumor are multifocal. We can see, the tumor usually preceded with the symptom of the endocrine hyperplasia. So we can go through that. Multiple endocrine one. We said 3P. 3Ps is what? What do you think? 3Ps means parathyroid, pancreas, pituitary. So you just remember multiple endocrine neoplasia 1, you have 3Ps. 3P, okay? So parathyroid will be hyperplasia. Pancreas, we have gastrinoma or insulinoma. Pituitary, prolactinoma, okay? So it is autosomal dominant inheritance. Multiple endocrine 1 gene is a tumor suppressor gene on the chromosomal 11. So if there is mutation in this gene, it leads to multiple endocrine neoplasia. So the 3 will be affected: parathyroid, pancreas, and pituitary. Okay, easy to remember, right? Multiple endocrine neoplasia 2 mutation, we said RET gene, proto-oncogene on chromosomal 10. Okay, so we can see here multiple endocrine neoplasia type 1A and type 2B. Usually there is, similar to each other. They have medullary and adrenal. So in medullary carcinoma, and also adrenal medulla is the pheochromocytoma. The difference only in the type 2A is parathyroid hyperplasia. In type 2B, we have extra endocrine manifestation like ganglion neuroma, marfanoid, habitus. Okay, so any question? Understood? Hello? Okay, understood. Any question? You have PPL at 11:30, right?
Yes.
Okay. Is there any question? Any question? So I can see only 117 attend. What is the rest? What is the rest?
I'm not sure, brother.
Not sure. Sleepy, isn't it? Is there any question? Understood the endocrine neoplasia? Hmm?